Thanks, Court. Hello, everyone. Welcome. And for those who I don't know, my name is Zohal. I'm an infectious diseases pharmacist here at NCAS. And thank you so much for joining our final NCAS Journal Club for the year. This was a bonus episode that we squeezed in. Consider it an early Christmas gift. And so on behalf of Courtney and Kaz Thursky will be joining us a little bit later. I do want to thank everyone for your support this year with our Journal Club webinars, for all of our wonderful speakers, but also you guys who have attended and contributed as well. And I'm also very pleased to welcome Professor Trish Peel, who will be presenting today. Professor Trish is an infectious diseases clinician researcher and also the Deputy Director of Research in the Department of ID at Monash University and Alfred Health. She is passionate about improving the outcomes of patients undergoing surgery, with a particular focus on preventing post-op infections. Most of you will already know for the significant amount of work that she's done in this space. She has extensive experience in leading large-scale randomized controlled trials in this particular area of preventing infections in surgery. And she's here today to tell us the results of the remarkable ASAP trial, and that we're all very excited to hear about. So thank you very much, Trish.
Thanks, Zohal, and thanks for the invitation to present. So I'll just share screen now. So thank you very much. So I'm really excited to be able to present this trial to you. This was a work that began in my PhD back quite a while ago, so it's always exciting to see it come to fruition. As Zohal said, this paper was just published in the New England Journal in October, and also just highlighting on this slide that it was a collaboration between infectious diseases doctors and also orthopedic surgeons. And so this is a really important thing to bring it to actual, to be able to recruit and be able to get outcomes, to have that sort of very rewarding collaboration. So probably everyone who's familiar with NCAS is probably aware of, the importance of antibiotic use in surgery, and in particular, the recommendations, which is that you only use antibiotics when recommended. And these are administered prior to surgical incision to help prevent patients getting surgical site infection. So the recommendations are to only use when recommended, but also to choose a spectrum that covers the most common organisms, but obviously not all of the organisms. So in Australia, with the therapeutic guidelines, we recommend using cefazolin prior to surgical incision in joint replacement surgery. And this we know that joint replacement surgery is very common. So it's probably one of the most common surgeries performed in Australia. And again, we're seeing sort of increasing numbers of surgery being performed. So this year, probably over 120,000 joint replacement surgeries will be performed. And then there's estimates that will increase substantially out to 2030. So our evidence of cefazolin is based on a randomized controlled trial which was performed in 1981. And this was a placebo-controlled trial in hips that showed that using cefazolin reduced the risk of infection. Over this time, we have been seeing a couple of things. Firstly, we've been seeing actually an increased risk of infection in our prosthetic joints. And data from Australia suggests that up to 6% of prosthetic joint surgery may become infected by 2030. So we're seeing increasing numbers, but also increasing risk of infection. And one thing that's been raised is whether that increasing risk of infection we're seeing might be related to the fact that we're seeing more resistant organisms causing these infections. And this is a paper from my PhD that looked at the risk of the patients who had an infection, what proportion would have received antibiotic prophylaxis to cover the organisms they subsequently isolated. And around about half didn't have antibiotic coverage that would have prevented that infection. So it really raised the question about whether we needed to be changing our prophylaxis. So in particular, we were seeing increasing risks of methicillin-resistant Staph aureus, but also methicillin-resistant Staph epi in particular. So really one of the questions that's been raised by us, but also by groups throughout the world, is whether we should be broadening cover to include vancomycin. Just as a segue and a learning point, we know that giving vancomycin on its own isn't as good as cefazolin. You see an increasing rate of methicillin-susceptible Staph aureus. So really the debate has been about combination prophylaxis. So this was the genesis of the Australian Surgical Antibiotic Prophylaxis trial, which was a multi-centre, placebo-controlled, double-blind, superiority randomised trial in joint replacement surgery. An important caveat was it was performed in patients without MRSA colonisation. So it was adult patients and a very much a pragmatic trial, just again highlighting that we excluded patients with known MRSA colonisation. We also excluded patients who were having surgery for trauma, for example, fractured neck of femurs. So the intervention patients were randomised 1:1 to standard prophylaxis with cefazolin 2 grams, plus the addition of 1.5 grams of vancomycin, or standard care cefazolin 2 grams plus a normal saline placebo. As an additional part of this study, we took nose and groin swabs from all our participants, in addition to any standard infection prevention approaches that might have been performed at the sites. And this was done prior to antibiotics on the day of surgery. And we cultured these organisms, particularly looking for Staphylococcus aureus, but also for other methicillin-resistant Staph epis or other coagulase negative Staphs, to see if that impacted on their risk of infection post-op. So the primary outcome was pretty standard. It was surgical site infection using the CDC definition, which is the commonly applied definition for these sorts of trials. And then we looked at secondary outcomes, including which joint, as well as some other safety outcomes, including acute kidney injury. So this trial began recruiting in January 2019, and last patient was randomised in October. So really able to do this trial quite quickly. And also importantly, despite COVID, we were able to actually continue recruiting despite statewide shutdowns for elective surgery. So we screened 7,000 patients, of whom 6,500 were eligible, consented 4,362, and 4,113 were included in the modified intention to treat analysis. The majority were female. Most of the patients were undergoing hip or knee surgery. We only had 30 shoulder replacements. And again, most were primary surgery with only a small percentage of revision surgery. So based on those swabs we took at the time of surgery, just under 30%, so 28.5% of the patients actually had methicillin susceptible Staph aureus on their skin at the time of surgery. And similarly, just over a quarter had methicillin resistant Staph epi on their skin at the time of surgery. So in this study, we had 163 patients who were confirmed to have a surgical site infection, so 4% of the cohort. The majority were superficial infections, but we did have some deep and organ space infections, which probably for clinicians would be more familiar with the term prosthetic joint infection. At the primary outcome, overall, we saw no difference between the group. There was a slightly higher proportion of patients in the vancomycin group actually that got an infection, but again, this was not significant. However, when we looked at the individual joints, we found that actually there was a higher proportion of patients who got infections in the vancomycin group, 5.7%, compared to 3.7% in the placebo group, and this was significant. There was no difference between the hips and only a few shoulders. So looking at the subgroup analysis, just stepping you through some of the important points, what we found was that males allocated to the vancomycin had a higher proportion of infections, and this was a significant difference, and it was driven by the knee population. Similarly, those in the average age group, which was 65 to 70 years old, also had a higher risk of surgical site infection in the vancomycin group, and again, driven by the knees. Interestingly, those who had MSSA on their skin at the time of surgery also had a higher proportion of infections in those allocated to vancomycin, although this did not reach significance. So we also did a per protocol analysis, the first one being whether they received the treatment to which they were allocated. And when we did this, we didn't find any difference either overall or in that knee population. However, we also had some patients who didn't receive the cefazolin at the time of surgery, the majority of which received clindamycin for reasons that we didn't collect, but usually it was driven by the anaesthetist choice. When we looked at this cohort, so did they receive the vancomycin or placebo, and did they also receive cefazolin? Again, no difference overall, but this difference in the knee was again observed. No differences were observed in any of the secondary outcomes, including whether there was differences in the type of infection or healthcare associated infections. So this is probably the bit that's generated the most interest and discussion, looking at safety outcomes. So we only had a few deaths in our cohort, and there was no difference in mortality between the two arms. However, when we looked at acute kidney injury, we actually saw an increased proportion of patients allocated to placebo who got acute kidney injury. And this was predominantly stage 1 kidney injury using the KD-IGO criteria. And this was significant. We can have a chat about this. I've got a few theories as to why we observed this. Not unsurprisingly, we saw a higher rate of hypersensitivity reactions in patients allocated to vancomycin, and this included 2 episodes of anaphylaxis, which occurred with the administration of the drug. Looking at the outcomes of infection, importantly, only 64 patients who had an infection, so 39% of the infections, had a microbiological specimen collected. When we look at the breakdown, just under half were Staphylococcus aureus, of which all bar 1 were methicillin susceptible Staph aureus. 1 methicillin-resistant Staph aureus occurred in a hip replacement who was allocated to vancomycin. And again, we saw a slight increased proportion in Staph aureus in the vancomycin group. And similarly, when we looked at gram-negs, we again saw an increased proportion of gram-negative infections in the vancomycin group. So always with trials, no matter how well you think you've designed it, there's important limitations. So again, re-emphasising that we did not include patients who were colonised with MRSA. So about 1% of the population were excluded because of colonisation with MRSA. There were small numbers of revision and shoulder surgery, so again, difficult to extrapolate the results to that. We had small numbers of deep and organ space infections, and part of that is because the CDC definition is only out to 90 days, where we know many of the deeper infections, the prosthetic joints, will present out to 2 years. And so we're now currently linking with the AOA Joint Replacement Registry to follow those patients up. In about 5% of cases, the clinician decided that they didn't want the patient included in the study, so there was potential selection bias for that. And we had disruptions due to COVID-19. But in conclusion, this study showed that the addition of vancomycin is not required for patients without known MRSA colonisation undergoing primary hip or knee replacement. So again, just focusing on the wonderful team that I got to work with, and also highlighting that we received NHMRC funding to do this study, and we would not have been able to do this work without that funding. And also just that these studies rely on engaged site research staff, orthopaedic surgeons and anaesthetists, as well as patients and families to be able to do these trials. And so we're very grateful for their willingness to participate. So I'll stop there, but very happy to take any questions, it's always happy to hear thoughts and so on. We've had a lot of discussions, I think, being generated about the trial, so I'm very happy to chat.
Thank you so much, Trish. Those are very, in some ways, unsurprising results, but in other ways, like you mentioned, there are some questions that have still been raised. I will start, I guess, with the initial findings that there was no significant difference in the overall cohort in terms of post-op infections. And how are you and your team disseminating this information with the prescribers at the point of surgery, whether it's the surgeons or the anaesthetists?
Yeah, so we're, as part of the process, as soon as the where the trial was unblinded and published, we disseminated the results to all the local sites who had participated. And I think partly because there was no impact, but also potentially because there was a risk of harm, all the surgical units have stopped using vancomycin just for the general cohort. So that's been quite an impactful thing. Obviously, the trial coming out has coincided with the update of the therapeutic guidelines. So obviously that will be potentially incorporated into those findings and those recommendations. And the other thing we've been doing is presenting to orthopedic surgeons. So we've presented to the we're about to present to the Australian Orthopaedic Association, but also presenting to the American Orthopaedic Association and others internationally as well, the Europeans. So again, disseminating the results. The other ally we found is also presenting to the anaesthetics groups. They're an ally because they hate using vancomycin. So they're actually quite delighted with the results because it means that they don't have to administer vancomycin for a sizable proportion of patients. So we found actually having them aware of the results has also helped to prompt surgeons as to whether they do or don't need vancomycin.
That sounds excellent. And like you said, a negative result is still equally impactful because many people in the audience will know that there are creeps in practices for different reasons. And there are probably different departments around Australia who have been incorporating additional antimicrobials, whether it's clindamycin or vancomycin, with good intentions. And so this trial is going to be excellent in, I guess, rebutting and minimizing unnecessary and potentially harmful antimicrobials in that space.
Yeah, you're right. I mean, I published my the cohort study back in 2012 saying, maybe we need to be reassessing our prophylaxis and we need to do a trial. But many of the surgeons I know have actually adopted using vancomycin in that setting. And I've had people quote me back saying, oh, well, this trial said we should. And I'm like, no, the trial did not say that. But we also, one of the sites that we were recruiting from had actually already changed over to using dual prophylaxis because they thought it was better for like you said, very good intentions. And that site, is to be commended because despite that, they actually agreed to be part of the trial, stop that practice to allow the trial to occur. So I think, if you're engaging with the surgeons and talking through the rationale to be able to develop the evidence and actually answer the question, I think was really important for all of us.
Definitely. And I'm sure there are lots of people in the audience who are thinking, how can I take this back to my surgical departments and relevant prescribers? So most of you will know that, yes, there's that NEJM article, which is recently available and excellent to share. And there's a few media statements as well that you shared, which have been excellent for conveying this as well. So if anyone has any questions in general, but maybe more specifically in terms of how to incorporate this into practice, how to have these discussions with the relevant prescribers, this is a good time to maybe share some ideas about how to do this, because the therapeutic guidelines update is coming. Do you have a general idea of how far away that is, Trish?
I think it's still particularly the surgical prophylaxis, we've just started the update. I know they're staggering the updates this time around. So surgical prophylaxis probably won't be until later next year.
Sure.
But I think they're releasing statements and things.
Yes.
Yes, but I guess the advice I'd give to everyone trying to do it is, one, to talk to the surgeons, but also talk to the anaesthetists. Don't forget the anaesthetists. They're very, very helpful.
That is a good point. If there are any other questions before I jump in, because I could keep talking to Trish about this all day. Court, did you have a question?
I was just going to say, even to the pharmacists in the room, if you get the opportunity to present at a journal club and presenting this paper to stimulate that conversation, that might be a great way of engaging with your surgeons as well. Because that's, how often can you get them all in the one room? So, and that's, sparking this debate. So, yeah. I did have a question though for you, Trish, more about the challenges of linking the data with is it OA?
The Australian Orthopaedic, OAA, NJJ, NJRR, yeah, the Joint Replacement Registry.
The registry,
Yeah,
yeah.
the registry.
Did you have to reconsent, or did you have that built in the ethics, or
Yeah,
just for like a bigger picture sort of thing?
Yeah, so I guess firstly, just for people who aren't aware, so the Australian Orthopaedic Association National Joint Registry has been in existence for now over 15 years, maybe more. It's one of the longest running joint replacement registries in the world. And they capture 99% of joint replacement surgery. So it's actually mandated by the Australian government that people enter that data into the joint replacement registry. And they track outcomes on the types of prosthesis being used and if there's signals around failure. So people might be familiar with, there was some failures of hip replacements where they were getting wear and having to be revised early. And so that the joint replacement registry was able to detect that. They also collect outcomes on infection, although it's only infection revision surgery for infection that they capture that, so that it's not doesn't pick up superficial infections and also doesn't always pick up debridement and implant retention. So that's linked to the Medicare number, and we, as part of the trial, we asked consented patients for access to their Medicare data, their MBS, PBS data, and then we're able to do data linkage based on that. So that was always something that we intended to do as part of the trial. It also allows us to do the health economic analysis to get that MBS and PBS data, but it is a separate consent form to a standard trial form. Again, anyone who's done any work knows it's a pretty ugly, cumbersome, not terribly patient-friendly form that then we have to get the patients to consent to.
And I think Trish, I'll go ahead, Court, sorry.
No, I was just saying thank you. That's really interesting.
Speaking of the patient recruitment, one of the strengths of this study is the sheer number of patients that you had recruited to this randomized control trial. And we know that these large-scale trials are often what's missing from a lot of trials in largely antimicrobial stewardship and other related infections and areas of research as well. Can you comment on how you navigated this, one in general, with so many different competing parties, but specifically during COVID, because you had a lot of your research that was disrupted in the COVID period?
Yeah, I wouldn't recommend doing trials over COVID period, but anyway, it's tricky. These trials are, really important in surgery prophylaxis. We look at the data, and Court can tell you this from her PhD, that actually a lot of the evidence is not great, and actually missing for a lot of procedures. So, for example, there's never been a randomized control trial in knee replacement surgery, but we extrapolate, which is what we do for a lot of procedures. So, there are a lot of gaps, and we recognize that. But to do these trials, because the outcome is uncommon, you do need to have large data set, large cohorts. And so to do that, you need funding. So we needed NHMRC funding. And again, we were very fortunate to get it, but it took about 3 goes to get NHMRC funding for the trial. So again, persisting with it was important. And then to get the trial actually up with the surgeons, I was very lucky to work with a couple of very engaged and very supportive surgeons, particularly Richard de Steiger, who was at the time the Deputy Director of the AOA National Joint Replacement Registry, and a very well-regarded, well-respected orthopaedic surgeon. So we were able to recruit from his cohort at the Epworth Hospital, but also he linked me in with some other high caseload or high case surgeons who, one surgeon does over 600 joint replacements a year. So, we were able to through those linkages, be able to do it. The other thing that perhaps helped with the trial is we did pay a per participant payment. So we were able to support research staff to go and recruit patients. And I think that's important. I know it's tough because of the financial environments, but if you're able to fund the researchers doing it, you get one, they're more engaged, they're more likely to be able to recruit patients, but also they're being paid to collect the data, and you get better quality data with that process. So, and you build up your network of surgeons and groups. So we were able to do that. Despite COVID, we had shutdowns of elective surgery in Victoria, but we were able to continue recruiting elsewhere. And then shutdowns happened elsewhere, and then we continued recruiting in Victoria. So we were fortunate that this is such a common surgery type that even with those shutdowns, we were still able to get the cohort together in quite a fast time, despite COVID. But yeah, I think probably key messages is persist with funding. If you think it's a good idea, find your champions. If you're working in a discipline like surgery, you need, well-respected surgeons who are going to bat for you.
Brilliant, thank you. We have a question from one of the attendees asking about the rates of VRE colonisation. The question is, have the rates of VRE colonisation decreased in the hospital at all?
That's something that we've obviously we did the swabs and we're looking at VRE. I think we probably only had one VRE, but it's a different cohort from the hospital. These are people coming in from the community rather than people who are in hospital. So you'll see varying rates of VRE colonisation. I think there's a paper by Kaki and Alan Cheng from a while ago, which reported a rate of 17% when they swabbed patients coming into the emergency, but that was at the Alfred and included a lot of patients who had been at, in the tertiary hospital, in a quaternary hospital, and particularly hematology patients. So it was a skewed cohort. So I think that probably overinflated the rate of community VRE. So probably a lot lower than that. But again, that's something that we're looking at.
Thanks, Lisa. And my other question is about the organisms isolated from those post-op samples. Do you have any comments about your expectations and what you found there?
I think the isolation of the gram negatives was much easier to explain. Obviously, if you've got we've got cefazolin, but we're adding in vancomycin, so you're potentially adding sort of really clamping down on gram positives, to put it in a sort of fairly simplistic terms. You may see replacement with gram negs. So that we thought was potentially the case. And again, that's similar to what's been reported in other trials. For example, those trials looking at vancomycin powder, you do see an increased risk of gram negs. So that was sort of easy. The MSSA is a bit that's got us a little more provoking a lot more thought. There is a couple of things we've been thinking about. One question that we thought about, but and looked into more detail, was whether, because of the infusion of the vancomycin, was the cefazolin not getting in time. So we know you want it to be within, 0 to 60 minutes of knife to skin, but that didn't appear to be the case. And then the question is whether do you see selection of different, more virulent strains of MSSA potentially, or is there an antagonism between vanc and cefazolin? These are things that we're exploring with the isolates that we've got sitting in our biobank. So don't have a very good answer for that, but that's something that we really are interested in and are trying to tease out now.
I think the question everyone wants to ask, and you've probably been asked before, is about the rates of acute kidney injury that was
yes. Definitely want to say I don't think that vancomycin is renoprotective. So I think we can put that one.
We don't want to hear that rumor.
Not going to be advocating that one. I think it is actually probably an artifact of the way we collected that data. So because it was a pragmatic trial, we weren't funding for additional collection of pathology specimens. We were relying on the bloods that the surgeons collected as part of standard of care. And so their standard of care is to collect bloods on day one post-op, and often then the patient won't have any other bloods. So whether what we were seeing is, potentially these patients had a dose of vancomycin, whether the renal impairment would have followed after the vancomycin. So maybe we weren't capturing it. Maybe it was going to be seen on day 2 or day 3, but because of the fact that we weren't doing daily bloods, maybe that's the reason why we saw it. The other thing is always in stats, and in trials, you do get some anomalies. So maybe that is, a type 1 error. So maybe we're just falsely finding that result. But I wonder whether it is actually more likely to be the artifact of collecting the bloods on day 1 rather than later on. But yeah, definitely not a renoprotective agent.
But you're right, that is a good point, and I guess something that you won't capture from those once-off early results.
Yeah.
I was going to say, even the dose of Vanc itself, though, it's not like it was like a massive loading dose for sepsis, or I mean, for the dose, that one dose in relation to,
so it was 1.5 grams. We did give 1 gram to anyone who was less than 50 kilos, which in this cohort wasn't that many. So it's unlikely that a single dose. Most of the trials that have shown in prophylaxis, when you use dual prophylaxis, there's been a couple of trials that have shown an increased risk of acute kidney injury with dual prophylaxis. And in those trials, they gave more 24 hours or more of vancomycin. So I think that may be why they saw an increased risk rather than a single dose. But yeah, I don't think it's a true finding, really.
And I guess I just want to say that adds on to the importance of your trial as well, Trish, is that it wasn't multiple doses after surgery too, and that it helps build that evidence base that we don't need multiple doses after surgery too. So
although the caveat is that we didn't we're tackling one problem at a time, so we didn't alter what they were doing post-op. So the majority did get up to 24 hours of prophylaxis. Not many, I don't think there were many who got beyond 24 hours, which is great, but that was of Kefzolan. Yes, we only wanted to look at one issue at a time rather than try and do multiple.
And which leads me to ask, so we've answered the important question from this particular trial. And what's the next question that you're interested in looking at in this particular cohort?
Tackling one big problem at a time. The question, which is sort of feeding into Courtney's question, is now we're looking at cardiac surgery. So we're doing the Calypso trial, which is another placebo-controlled randomized trial where we're randomizing people to 3 arms, intraoperative only in cardiac surgery, 24 hours or 48 hours post-op, in patients who throughout Australia, but also internationally now, who are undergoing cardiac surgery. So that trial's underway. There's a number of sites. We've got about 17 sites already recruiting in Australia, and sites in New Zealand and so on. So people might be familiar with it. And we're recruiting 9,180 patients because yay. It's but that's that will be an important trial to see whether you do need post-operative doses of prophylaxis in cardiac surgery. We know that's an area where there is a lot of antibiotics being used. Part of me wonders whether showing that it's okay that you don't need post-operative in cardiac, whether that will influence other surgical types, but I think that might be over optimistic about how surgeons view the evidence. So maybe I'm just going to be doing perpetual trials.
I think it is a good one, obviously, of interest, given that the cardiac surgery is one where the duration of post-op antibiotics has creeped longer and longer and longer for various reasons.
Yeah, I mean, part of the reason is that there is evidence to support giving post-operative doses. It's not great evidence, but it's evidence. So I think until we do these sort of trials, we're not going to change the barometer on that one.
When can we have you? But when do you hope you'll have some data for us to have you back for Calypso for Journal Club, Trish?
Well, the cardiac one is it's an adaptive trial. So we are able to drop arms if there's potential issues. So maybe we'll be able to do that towards the end of next year. We'll have the first interim analysis when we've got 3,000 patients. So maybe depending on what we find. And I guess the other thing we're going to be doing, which might be of interest, is that we're setting up an international platform trial looking at perioperative infection prevention, but obviously antibiotic prophylaxis will be one of the main things. So hopefully then we'll be continually presenting and updating the evidence for you all.
we're looking forward to it. Are there any other questions from the audience that anyone wants to raise? We can unmute you and you could just ask in person, or feel free to put it in the chat. I think you've answered a lot of the questions that were on everyone's mind. So it's been a good opportunity to have this forum for those reasons, for the questions that we had personally, for the questions that I know that others have had, and I'm sure there are further questions as well that will come up. Got some background noise, sorry. And Court, if there aren't any questions.
Yeah, I guess just wanting to flag with everyone that, yeah, this is our last one for the year. So thanks everyone for joining us on the journey of NCAS, not quite journal club. We haven't reviewed too many papers. It's definitely come out to be more of a seminar series, and I think that is the platform that we're going to be taking going forward into 2024. We're very open to suggestions and ideas. So if anyone online has any suggestions, doesn't have to be in the chat right now, but support@naps.org.au is the email address to get in touch. We will have a break in January, but we'll get the ball rolling back in February. So keep an eye out on our socials, the newsletters, and we'll have a registration link to get forward for then. So, yeah. And thank you, Trish, for joining us. It's always a pleasure to have you.
Thank you.
Thank you, Trish. All the best. We look forward to hearing about the Calypso trial next.
Yes. Thanks. See you all.
Bye, everyone. And thank you, Zohal, for facilitating today. Wonderful hosting. You know you're going to get roped into doing this more and more and more.
I'm sure they miss you, but yes. Thanks, everyone. Have
Thanks,
a good
Bonnie. Thanks, Zohal. Bye.
Thank you, everyone. Bye.